if you wouldn't mind, introduce yourself, give us a little bit of your background, and share with us why you either got involved with the company or why you started the company.
Yeah, no, thanks very much, Tony Amato. Actually, my first name is Antonino, but too long and complicated to be pronounced in the US. Always mispronounced as Antonio many times. It's Antonino, which it's a name from the south of Italy. Doctor by training, surgeon by postgraduate education, oncological surgeon by activity for 13 years. Always involved in clinical research, and I loved to continue clinical research. So I moved from academia and then hospital into private industry, into pharmaceutical industry. Spent 24 years in one company called Sigma Tau, today part of a larger conglomerate called Alpha Sigma, merger between two mid-sized Italian companies. Current turnover, turnover when I left the company, 1.2 billion euros, so a large company. I spent 10 years in that company in the US, as I said, based in Washington, DC. Actually, Bethesda, Maryland was my site, my residence. I have had an apartment in Bethesda up until last month, when I sold it after several years, following the big bubble burst that occurred in the mid-2000s. Came back to academia after Sigma Tau for 6 years, here in Rome, in my alma mater, where I started a clinical trial center that was non-existing. And then I got lured into developing compounds, which is probably what I like more than developing services, which was the clinical trial center venue. And I've been at the helm of BetaGlue Technologies in the last 3 years, since July 2018. Very interesting technology. I had overviewed a similar project whilst I was in Sigma Tau. It was called IART. Actually, it's published in several places. It was a joint venture between Sigma Tau and the European Oncological Institute in Milan, Italy, where Professor Veronesi, former Ministry of Health in Italy and a famous oncological surgeon, had been positioned for several years. So it was a joint venture that was developing a technology based on 90-yttrium, very much like BetaGlue's technology. I loved that old project when I was approached for this position. I liked the technology, stayed for 3 months as a consultant to the company to understand better the technology and the situation. And then I decided to come on board, and I've been doing this, and I've been in this position ever since.
So what exactly does your company, what problem do they address?
Yeah, the problem that the company is addressing is that of providing a more cost-effective, easy to prepare and administer, and safe form of radiotherapy that can either help ablate tumors when they are not resectable, or can be used to clean the surgical bed after resectable tumors removal, with the intent of clearing the surgical bed from any remaining minimal residual disease.
Who specifically experiences that kind of problem? And can you maybe give an example of who might benefit from this?
Sure. As you can imagine, radiotherapy is very prevalent in the life cycle of cancer patients. More than half of them are exposed to radiotherapy in their life with cancer. So several patients can benefit of it. We have chosen to dedicate our efforts on two specific clinical conditions. Patients with unresectable primary and secondary liver tumors for the intratumoral injection of our radioactive glue, whilst the other application, the surgical bed application, is going to be explored and assessed in patients that have had early breast cancer removal by surgeons.
Tell me in very, very simple terms, tell me how your product works.
Sure. This is a radioactive glue, which is why the company has been called BetaGlue. It's a beta emitting, i.e. radioactive glue. This is a combination of two components, microspheres and charged with 90 yttrium, and a glue that is actually a sort of a conduit of the microspheres, and by very rapid polymerization allows the microspheres to be stuck exactly where they are needed to release their energy. This radioactive glue polymerizes in 30 to 120 seconds upon administration on the target site, and ensures that the dose of radioactivity, which is personalized according to the size of either the tumor to be ablated or the surface to be cleared, to exert its action. That's how it works. And it's a very smart combination developed by those two academicians I had mentioned before, who took advantage of the very well-known fact that microspheres are indeed effective in releasing their energy charge by 90 yttrium decay, whilst at the same time, the issue of those microspheres that could be gotten loose in the site of administration is avoided by the rapidly polymerizing glue selected for this specific task. The combination of the two has made our technology, and I think it was a very brilliant idea on their part.
Yeah, it sounds very fascinating. So what is the issue if the radiation doesn't stay where it's intended?
Well, this is really something that is plaguing the current brachytherapy world. As you know, there are several brachytherapy tools and devices which have been developed and are on the market. And their issue is actually that they do migrate. Once inserted in a place, they tend to migrate in a variable percentage of the cases, depending on the type of device, site of administration, and expertise. Last but not least, of the surgeons or the nuclear medicine physicians. This is not happening without technology. The glue polymerizes wherever it's being administered, and it's already reaching a very good tension in 30 to 45 seconds, and is fully polymerized in 120 seconds. So our preclinical studies have documented that 1 week after administration of our technology, around 1% of the original radioactivity can be found either close to the site of administration or in other stations of the body. This is a very, very limited amount of radioactivity which gets lost compared to, for instance, brachytherapy or even EBRT, whose beams have to cross the body to get focused on their target. So there is a necessary dispersion of the radioactivity that those beams carry with them.
How big of an issue is that? Does it affect 60%, 40%, 20%, 10%? How big of an issue is that?
In terms of brachytherapy, this can be as big as 30% of the patients, depending on their site of administration. For external beam radiotherapy, all the patients actually get exposed to unnecessary radiation due to the beams converging through the body onto their intended target.
What's the biggest challenge that you feel like you're facing right now?
Well, for BAT90, I would say that the biggest challenge is, entering into humans all along. I mean, although, as you know, what you test in animals is not often the case replicated into humans. But in our case, the technology is a technology that is effective and or safe due to the physical characteristics of its components. This is not an antibody that needs to bind to a receptor that between a mouse and a human might be different. This is radioactivity. The physics of yttrium are identical, regardless of whether you apply them in an animal or in a human being. And the same for the glue. So at the end of the day, we don't feel that the jump between preclinical and clinical will decimate, will kill the very large number of projects that undertake that step. So our real challenge is to be into humans and prove the promise that this technology has given us in animals. I think that it is very, very likely that what we have seen in animals is replicated into humans. The evidence is very strong and compelling preclinically. And I would say, in addition to proving its own merit, the other challenge is clearly to find adequate resources to allow us to proceed in our development.
Is there any last thing that you'd like to leave us with?
Well, I can only express to you the excitement of a surgical oncologist that loves to develop technologies to help patients. I think that this is a smart technology. I am very appreciative and really in awe in front of what these colleagues have invented one day using two already available technologies. It makes a lot of sense. It covers a very big unaddressed medical need. It goes beyond the limitations that each of the components or other technologies used in the same clinical indications do have. So I think it's an exciting time for me and for anybody that is in this arena to find themselves into. Last but not least, I would say that having seen the booming of therapeutic nuclear medicine over the last few years, something that has changed, from the old diagnostic scintigraphies that were just there to make, to confirm some diagnosis. Today, you have nuclear medicine for curative intents, and that's very, very new. Has attracted big players like Novartis, let me mention AAA and Endocytes acquisition. Today, a very, very beautiful paper on the New England from Endocytes team on PMSA in prostatic cancer. I think it's an exciting time, and I think that BetaGlue is very nicely positioned to be there at the dawn of the new year.
Thank you for watching the Lowdown on Cancer presented by the Cancer Fund. To learn more about what's coming in future episodes, visit us at www.cancerfund.com. While you're there, check out past episodes and be sure to click join us to become a member of the Cancer Fund community. As a member of the community, you'll receive early access to new interviews as well as other announcements. Make sure to connect to all of our social media channels so you don't miss a thing. In addition to getting early access to new episodes of the Lowdown on Cancer, Cancer Fund members play a critical role in driving cancer innovation forward so that one day we can more than hope. We can actually beat cancer. Thank you for joining us on this journey.